the weather conditions. IPSS Medical Rescue Samantha Merrick says beachgoers came across a body earlier today and they established it was the body of the 17-year-old missing teenager. More news now. The Polokwane Regional Court has postponed the bail application of Limpopo pig farm owner Zachariah Olivier. His bail application has been postponed to the 18th of February when he will rejoin his co-accused Rudolph Devet and William Masuro at the Makweng Magistrate Court. The trio allegedly shot and killed Mariah Makato, Lucia Ndlovu and fed their bodies to pigs at a farm in Sebaeng outside Polokwane in August. They face charges of murder, possession of firearms, ammunition, as well as defeating the ends of justice. A family representative, Samuel Makato, is wading in.
Yeah, that's true. He was just crying. And then that was a surprise from our side because the killing really, it caused a damage in the family. And from our side, we wish that the law must just take its route so that he can be placed in prison for what he has done. Actually, he's crying to us. It was really a big surprise because that was painful from our side. Even the children, the 4 sons that are left, it's still very hard for them to cope in life. You see, that is what we can say as a family.
In more news now, the rescue efforts are ramping up in Stilfontein as Phase 2 begins there. Cameras will be sent down the abandoned shaft in parts to determine the number of miners still underground. Over 1,000 miners have resurfaced after Operation Valamgo, the cut off food, water and medical supplies. Report says that the operation is expected to last several days before the first group is brought to the surface. More news now. The clock is ticking for prepaid Eskom customers to upgrade their electricity meters. The utility is warning it will not be extending its Sunday deadline. At least 2 million customers are yet to upgrade and could face the dark come Monday. Amanda Kiti of Eskom is waiting in.
Yeah, so I think people, you know that in the past when transformers or any of our mini subs fail, we would issue the fines to those customers. That's a separate process. I think at this point, our key focus is to ensure that customers come through, they buy electricity so that we can record their meters. Because at the moment, our drive is really on making sure that customers record their meters, which is upgrading of their meters from KRN1 to KRN2. I mean, you see they came in numbers. We've made a lot of them to go and buy electricity because we are close to areas that are selling electricity. Majority of them were able to buy electricity, and those who were not able to buy electricity, we are registering their meters so that immediately when they leave here, they go buy electricity so they can get the key change tokens and upgrade them. And millions that we lose from zero buyers. If I give you a number for Gauteng, it's more than 400,000 customers. We have about 857 out of those 857,000 prepaid customers, 400 and something of those, 400 and something thousand of those customers are zero buyers. So
the international story, the chief to Israel after the International Criminal Court (ICC) issued arrest warrant for senior Israeli officials over war crimes in Gaza. The ICC's pre-trial Chamber 1 issued warrants of arrest for Israeli Prime Minister Benjamin Netanyahu and his former Minister of Military Affairs Yoav Gallant for crimes against humanity and war crimes committed from at least the 8th of October 2023. The arrest warrants mean that those accused could face arrest should they travel to one of the ICC's 124 member states. Earlier today, Major General Hussein Salami described the warrants as a great victory for the Palestinian and Lebanese resistance movements, noting that the regime has become isolated. Your weather, 29 degrees. A quick reminder of our top story. Body of a teenage boy who drowned on South Coast Beach has been found. That's
as heavy snow and bitter winds descend on Gaza, Afghanistan, and Lebanon, hundreds of displaced and refugee families struggle to survive the winter. Without adequate shelter or clothing, the harsh weather threatens lives. Donate towards AMA's Winter Rescue Campaign to provide the food, fuel, and shelter needed by families in Gaza, Lebanon, and Afghanistan. to survive the elements and provide warmth to those in need.
This most repeated dua of Prophet Sallallahu Alaihi Wasallam is brought to you by Continental Butcher Baker Delhi. Quality, freshness and value. Our promise to you since 1992.
يا مقلب القلوب ثبت قلبي على دينك.
If you're looking for a delicious selection of freshly made baked goods, decadent deli treats, and succulent meats, there's no need to chop around anymore. Continental Butcher Baker Deli offers an award-winning service, presenting exceptional quality at competitive prices. Superb choice-grade lamb, beef, and chicken, mouth-watering homemade processed meats and gourmet marinades, and scrumptious baked goodies. Quality, freshness, and a money-back guarantee. Visit Continental in Argyle Road.
Continental Sausage Circus, now featuring 80 different types of sausages. Hurry before there's not a sausage.
Looking for the perfect gift? Then look no further. The Al-Ansar shop has a wide range of international brands of perfumes, books, games, and also the latest in kitchenware, trendy bags, and much, much more at all affordable prices. Visit us at 207 West Road, Overport, or call us on 031 208 1601. Al-Ansar shop, your one-stop Islamic shop.
Radio Al Ansar, 24/7, 365.
Are you concerned about prostate health and erectile dysfunction? Then join me, Faizal MJ Suleman, this Friday at 9 p.m. on Let's Chat as we delve into the latest medical advancements and expert advice. We will be discussing men's health, prostate issues, erectile dysfunction, and breakthrough technologies with our special guest, Dr. Lucio Fritella, a specialist urologist. All of this Friday evening at 9 p.m. on Let's Chat.
أحب الوفاء بشتى الصور أحب الوفي الأمين الأغر فأهل الوفاء كلون السحاب وحسن الربيع.
أعوذ بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. الحمد لله رب العالمين والعاقبة للمتقين والصلاة والسلام على رسوله الكريم سيدنا محمد وآله وأصحابه أجمعين برحمتك يا أرحم الراحمين. All praise is due to Allah, the Lord, cherisher, nourisher, sustainer, and master of the universe, the most gracious, the most beneficent, the most merciful. Ya Allah, it is only you that we worship and is your guidance that we seek. Ya Allah, keep us in the straight path. Ya Allah, show us your choice of blessings. Ya Allah, show us your mercy. Ya Allah, guide us. Greetings, salam, salutations on our beloved Nabi Muhammad Rasulullah Sallallahu Alaihi Wasallam. Yes, it is the Friday evening, the 22nd of November 2024, the 21st of Jumadul Ula 1446. Assalamu alaikum wa rahmatullahi wa barakatuh, and welcome to Let's Chat on Radio Al Ansar with myself, Faizal and Suleman. Yes, it is an absolutely beautiful evening here in Durban. It's absolutely humid, very, very warm, but very, very pleasant. Our topic for discussion this evening is men's health and new technology that deals with PSA. And our special guest is Dr. Lucio Fritella, a specialist urologist and partner at Bhagwan Fritella Urology. Dr. Fritella, good evening to you, and thank you for joining me in the program this evening. Dr. Fritella, good evening to you. Can you hear me? Dr. Fritella, good evening. Can you hear me, sir? Okay, I don't think Dr. Fritella is hearing me. We're not hearing him either. Okay, I think Dr. Fritella is on an emergency call right now. So what will we listen to in the sheet and then start off that after the sheet?
أحب الوفي الأمين الأغر فأهل الوفاء كلون السحاب وحسن الربيع وماء المطر أحب الوفاء بشتى الصور أحب الوفي الأمين الأغر فأهل الوفاء كلون السحاب مقامهم فوق رأس الجبال وفوق الروابي.
With prostate cancer being one of the leading health concerns for men, early detection and management are critical. Exciting advancements in medical technology now allow us to monitor PSA levels more effectively, potentially saving lives and improving outcomes. Dr. Fritella is a specialist urologist and partner at Bhagwandin Fritella Urology. He completed his undergraduate studies at Wits Medical School in 2006. He left Johannesburg to work in the urology department at Gray's Hospital in Pietermaritzburg in 2014, where he specialized and completed his master's in urology. He is a general urologist with the experience in the diagnosis and treatment of prostate cancer as well as other urological diseases. Dr. Lucio Fritella, good evening to you and thank you for joining me on the program this evening.
Hi, good evening. Nice to see you. Nice to meet you.
Likewise. Now, Dr. Fritella, just for us, just can I say, dive into the discussion. Can you briefly explain what is PSA and why it's important in men's health?
Okay, maybe it's better to perhaps start with what is the prostate. So the prostate is a structure, a glandular structure that sits at the bladder neck, at the base of the bladder, where the urine is to flow out of the bladder, almost acting as doors to the entrance of your bladder or the exit of your bladder. So the structure is important in men. Obviously, it doesn't exist in women. So part of the function in men is that it assists in continence of the urine. So it maintains continence, so we don't leak urine when we cough or when we sneeze. It's one of the structures that allows the urine to remain in the bladder. So when we talk about PSA, it's an important substance that is produced by the cells of the prostate. And the actual function of PSA, most of the PSA that is produced actually ends up in the male's ejaculate, in the man's semen. And it functions to allow that semen to remain fluid enough to assist with fertility. So it sort of liquefies the semen, the ejaculate, and enables the sperm cells to flow more freely within that fluid to assist in fertility. So that's the function of the actual enzyme called PSA. So PSA stands for prostate-specific antigen. And what it is this enzyme that has this specific function in men. So when we detect PSA, when we test for PSA, we're measuring PSA that is not in that seminal fluid, that PSA is now in the blood. So when we detect PSA in the blood, it means there's some abnormality in the structure of that prostate that is allowing the PSA to move from the ejaculate fluid into the bloodstream. So that can be caused by a number of problems. Obviously, the most pertinent one and pertinent to this discussion is prostate cancer, but there are a number of other conditions and situations where the PSA can leak out of the prostate and into the blood. So one of the other reasons for PSA to be elevated is if there's a lot of inflammation of the gland or infection of the gland, any trauma to the gland, as well as just having a large gland can also cause PSA to be detected in the bloodstream. Yeah?
No, you can go on. Sorry, you can go on.
Yeah. So when we talk about PSA, what we're talking about is measuring that substance that is found in the ejaculate, but when we're picking it up in the bloodstream, there's some abnormality with the prostate that we then need to investigate further. It's not very specific, it's not disease specific, but it is very organ specific. So there can be no pathology outside of the prostate that's going to give you a high PSA. You won't get a high PSA from a pneumonia or from a liver disease or something like that. It's very organ specific, but it doesn't tell us what disease is affecting that structure. It just tells us there's some pathology within that gland that we need to investigate further.
At what age should men start getting the PSA levels checked regularly and why?
So there's a bit of controversy in this. We need to sort of separate men into two groups when we talk about PSA testing. There's PSA testing in men who have symptoms of prostatic disease, which we can talk about briefly in a moment. But there's two groups. So there's men who have symptoms of prostate disease, and there's men who are asymptomatic. So when we talk about your asymptomatic group, that is men who have no symptoms, are passing urine well, have never had any problems, when should we be concerned, or when should we test them if we're concerned about a possible cancer in their prostate? So we divide those into certain groups. There's low risk and high risk groups. So your high risk population are men who have some genetic factors. So if there's a family history, a strong family history of men in their family with prostate cancer, and then those men we should start testing earlier. This population also includes, which is important in the local context, is African men. So African men, regardless of whether they have a family history or not, are considered a high-risk population, because based on population studies that we've done, we find that that population tends to present much earlier with much more aggressive disease. So what we recommend in the African population is that men should be starting to test from the age of 45. And that goes again with those high-risk people as well, anyone with a family history. From the age of 45, you should be doing your PSA regularly. Then it will, and then outside of that group, men should test after the age of 50, or from the age of 50. They should start measuring their PSA. In terms of what intervals we require, so then that will depend on what your initial result is. So if your first PSA is less than 2 above the age of 50, you can wait 2 years and then repeat it again. If it's more than 2 but less than 4, you need to check it every year. So that's sort of how we do it in the asymptomatic group. Obviously, if you have symptoms from the prostate, the scenario is slightly different, and those men should get a PSA regardless of risk factors or age or anything like that. If you're starting to experience difficulty passing urine, ever see blood in your urine, those kind of symptoms, that warrants testing anyway. There are some cutoffs as well that we recommend. It's also important to know when not to do a PSA.
Okay.
Or when not to test someone for prostate cancer, because we know that prostate cancer is not can often be a sort of a benign disease, sort of an indolent disease. Not benign is not the right word, but an indolent disease where the prostate, you can have prostate cancer, but it's not going to affect the quality of your life or your life expectancy in any way. So in men who have a life expectancy of less than 10 years, so if they have a lot of multiple medical problems, poorly controlled diabetics, patients who've had severe heart disease with bypasses, and they're already in their late 60s, we don't really recommend trying to chase for a prostate cancer in that scenario, especially if they're not having symptoms. So there's certain cutoffs that we would stop testing your PSA where we don't think it's going to result in any benefit whether we find cancer or not. That also applies to men who won't be keen for any of the treatment options that we have. So if they're not going to want treatment for their disease, there's no point in diagnosing it. Yeah. So when we test for prostate cancer, we do still consider your PSA as your first line of screening. So if you have no symptoms and you go for a PSA, then we would consider that a screening test.
You're listening to Let's Chat on Radio Al Ansar with myself, Faizal MJ Suleman. Our topic for discussion is men's health and the new technology that deals with PSA. Our special guest this evening is Dr. Lucio Fritella, a specialist urologist. And if you have any questions for Doctor on this particular topic, you may forward them to us via WhatsApp on 060-904-1056. I repeat, 060-904-1056. Now, Dr. Fritella, there's a lot of talk around the effectiveness of PSA testing in detecting prostate cancer. Now, how accurate is this, and can it sometimes lead to false positives or unnecessary biopsies?
So as we briefly touched on, there's a lot of conditions that can cause an elevated PSA that's not other than prostate cancer. So the challenge for us as urologists and even as general practitioners is to try and determine now which patients who have a high PSA warrant further investigation and which ones can we watch and wait and which ones can we ignore completely. Unfortunately, there's no hard and fast rules at this stage. There are a few areas that show some promise in terms of trying to find a test that will tell us which patients have got aggressive prostate cancer versus those patients who don't have prostate cancer at all, or who have a type of prostate cancer that's unlikely to bother them. So what we can do is the PSA can be broken down into two types. There's a free PSA and a total PSA. And when we measure the ratio between your free and your total PSA, which is quite simple, it's just a blood test. They often add it on at most of our labs. And if we find that your free PSA is very low, then that will guide us, that gives us more of a suspicion that there might be a cancer involved here. The other thing that we can do, and that we do, is that we examine our patients with a rectal examination. And if we combine that with the PSA, if we have a high PSA already, and we feel that there's a very hard mass or the prostate feels irregular in any way, or we feel some sort of nodule, then that will also warrant a biopsy or further investigation. Another option that is becoming increasingly common, and that is recommended now, is that in patients with an elevated PSA, we do an MRI scan of the prostate. An MRI scan is very useful because it will allow us to firstly determine whether there are any lesions within the prostate that warrant further investigation. It also tells us where those lesions are, so that when we do our biopsy, we can focus that biopsy and hopefully detect the cancer where it is, as opposed to just firing off randomly, which is what we've been doing up to now. So between a free PSA, a rectal examination, and an MRI, basically those are the most useful ways of discriminating between a high PSA from other reasons and a high PSA from a cancer. Having said that, nothing is set in stone, and we often find cancer when we're not expecting it, and we often find benign disease when we 100% almost tell ourselves this patient's definitely got a tumor. So there's nothing in medicine, unfortunately, is 100% science. There's still a bit of nuance and a bit of uncertainty in what we do.
Doctor, how do urologists differentiate between high PSA levels caused by benign conditions like prostatitis or enlarged prostate versus cancer?
So again, if we go back to our basics of what the prostate is and where it sits, and there's different functional areas of the prostate. There's different zones of the prostate. Okay, so we break down the prostate into a central zone, a transitional zone, and a peripheral zone. And what we know is that our cancers occur generally in the peripheral zone of the prostate. So unfortunately, that means that the symptoms from prostate cancer often occur much later than the symptoms from your benign diseases. So patients who are having difficulty passing urine, it's very often much more a sign of your benign diseases than of your prostate cancer. When it's cancer causing that obstruction, it's often advanced. The way that we actually end up diagnosing the cancer is with a prostate biopsy. So a prostate biopsy is a test that we do. It's normally done, it can be done in the rooms. It's often done in theater under an anesthetic, where we pass a needle through your prostate and we sample your prostate. It's a fairly what would you say? We use a fairly random strategy, and we sort of shoot scattergun approach at the prostate, and we try and get good representation. And we take a number of shots through the prostate, normally 6 from the left-hand side and 6 from the right-hand side of the gland. And then we send that for testing to the laboratory. And if that comes back positive, then we have a diagnosis of prostate cancer. It will also tell us if there's any other disease there. It will tell us if there's inflammation or infection. It will tell us if there's just glandular hypertrophy. So that is the definitive diagnosis. That's the definitive test to discriminate between prostate cancer and benign disease. It does come with risks. Obviously, any surgical procedure does carry certain risks. The ones that are specific to a prostate biopsy, obviously there's a lot of blood flow to the prostate, and so we can cause some significant bleeding from time to time. It will present as blood in the urine or blood in the urinary bladder. There can be some bleeding at the rectum. It's a procedure that involves going from a sort of a dirty area in the rectum into a sterile zone, which is your prostate and the bladder. And so we can transmit infection into the prostate and into the bloodstream. So one of the severe risks of a prostate biopsy, it does carry about a 1% risk of death from a prostate biopsy. So it's not completely benign, which is why we constantly on the lookout for less invasive ways of finding cancer. So we try and avoid biopsies as much as possible, but it is, unfortunately, it is the only way to diagnose prostate cancer. There are there's a trend now towards a procedure called a transperineal biopsy, because historically prostate biopsies have been done through the rectum. So now there's a new technique where we approach the prostate through the perineum, which is the area between the scrotum and the rectum, which allows for a much cleaner procedure. It's not involving any fecal matter, any rectum, anything from that area. It just goes through the skin of the perineum and directly into the prostate. It does require slightly better training, some advanced techniques. You need a different ultrasound machine to guide the prostate, to guide the biopsy. So it's not completely available everywhere, but it is becoming more and more recognized as the way to do prostate biopsies going forward. If you combine that strategy with your MRI findings, there's a new technology where there's incorporation between your MRI and the ultrasound that we use during the biopsy, which is called an MRI fusion biopsy, which sort of maps the prostate that they see on the MRI onto the prostate that we're seeing on the ultrasound, which then allows the surgeon to target that biopsy specifically to the areas that look suspicious on MRI. So there are we are moving forward slowly, but again, these are not things that are universally available and are not often accessible, especially in our setting where resources can be a challenge.
Now, we've sort of alluded to invasive procedures. Are there any innovations in PSA testing that allow for more accurate non-invasive diagnosis?
So we did mention there's that free PSA ratio, the free to total PSA ratio, which can be helpful. There's a concept called PSA velocity. So if we measure your PSA at point A and we measure it again at point B, and that time and it's increased, and we know how much time has gone by and we know about how much it's increased. If it's increasing at a certain rate that's more rapid than we would expect, then that does make us more worried about a cancer versus a benign process. The other method is we measure the volume of the prostate and we compare that to the PSA level, and we call that your PSA density. So obviously we expect a larger gland to have a higher PSA. So we accept a higher PSA in a large gland. Now, if you have a small gland, so normal prostate should be about 20 to 30 grams. So if you have a 20-gram prostate with a very high PSA, that's more concerning than someone with a 60 or 80-gram prostate with that same PSA. So when we look at your PSA density, that's another way that we can discriminate between benign disease and malignant disease. Again, it's guesswork. It's based on studies and it's based on algorithms, a lot of which comes from overseas and different patient cohorts that don't quite fit our demographics and that don't quite fit our genetic risk factors in South Africa. So we can't really apply them as easily as we'd like. There are some newer tests on the horizon. There's a test called a 4K prostate test, which is another. So there's your PSA, there's your free PSA, and then there's two other bioforms of PSA, which they add to that test, as well as your demographic information. And then there's an algorithm that we plug it into there's a calculator, and then that gives us a risk of cancer versus no cancer. Again, not available here. It's been developed in a US lab, and we don't have access anywhere here. I don't think any of our labs are doing it. So there are some things that are coming, but at the moment are not exactly readily available for us.
Let's look at artificial intelligence and machine learning. How is AI and machine learning integrated into PSA testing and prostate cancer screening?
So those algorithms that we mentioned, where you combine your blood tests with your age, your race, your family history, certain genetic testing. Where AI comes in useful is it shortens our time to do that analysis and to spit out that risk. Instead of us physically having to enter all of those data into an algorithm, we just put it in once, and then the AI can spit out a risk for us, and we can base it on that. The second place that AI is useful is in your pathology. So in the histology side of things. So when we send a specimen to the lab, it gets looked at. We send them maybe 12 or 15 pieces of tissue, and the pathologist sits in the lab and either looks at all of them or looks at a few of them and then gives us the result. So an AI or a large language model with image training will be able to look at those slides at a much quicker rate and have all of that background learning already inbuilt and give you much more accurate and much faster diagnoses. Potentially. Obviously, no one's really doing this stuff, but these are the sort of possibilities of AI in prostate cancer and screening and treatment. Again, in a similar way, when we're doing our MRI scans, instead of a radiologist having to sit there and maybe it's his 13th scan of the day and he's tired and he hasn't had his coffee yet, you may get the standard of reporting might change. If it's a machine that's looking at the pictures, it's going to give you the same standard of reporting regardless of mood and feelings and emotions and tiredness, all of those things that human beings suffer from. So those are the possibilities, especially in the imaging, which is your radiology, your MRIs, your CT scans, and then in your in the pathology side when they're looking at the slides. If we can automate that process and make that less dependent on human error, then I mean, obviously we don't want the AI to take all of our jobs, but hopefully they'll still need the surgeon to take the biopsy, but we'll see what the robots can do.
Yeah, let's see how it pans out. You're listening to on Radio Ansar. We are discussing, yes, I know it's a Friday night, but we're discussing men's health and the new technology that deals with PSA. Our guest is Dr. Lucio Fritella, a specialist urologist. And if you have any questions for Doctor on PSA, you can forward them to us via WhatsApp on 060-904-1056. We'll visit the marketplace and continue on the other side of this. Doctor, do stay with us.
November is here with unbeatable savings from Simplex Radio.
Save 500 Rand on the Kenwood home mixer, now just 1799.
The D5 4.7-liter air fryer is only 799, saving you 400 Rand.
Philips irons starting at just 299 Rand.
Plus save 300 Rand on the Midea 20-liter microwave, now only 799 Rand.
Don't wait. These incredible deals won't last long.
long.
Simplex Radio, the name you can trust.
Nando's at Saxony Westwood Mall is NIHT approved. Get ready to light up your taste buds with our legendary flame grilled chicken, the taste you trust. From juicy combos, mouth-watering burgers, wraps packed with flavor, bougie bowls, and platters that bring everyone together. We've got deals to make your mouth water. It's the OG of flame grilled goodness. Head on down to Nando's Westwood Mall, bringing the heat one bite at a time.
As promised at last year's Durban Summer Cirque, part of our profits will go to making a real difference in our community. The Al Ansar Foundation proudly completed its first borehole for the community of Redcliffe. With water shortages affecting many, our mission is clear. Let's bring clean water to more areas in need. Join us in making an impact. Call Outreach on 031 208 1601 or visit alansar.org.za to help build more boreholes and transform lives.
Plan your dream holiday with the specialist, World of Travel, as we pride ourselves in offering you the best in Hajj and Umrah. We also offer travel packages to the Middle East, Far East, and many more exotic destinations. Call our professional travel consultants now on 031 20 888 77 or view our website www.worldoftravel.co.za. Visit us at 44 Crescent Street as memorable journeys begin with World of Travel by Irshad Malik.
Want to tantalize those taste buds? Halton's has you covered. From freshly baked treats to imported confectionery that brings international flavors right to your door. Indulge in our daily food menu, home industry goodies, and those household brands that you love, now with global twists. Visit Halton's at 358 Brickfield Road, open till 9 p.m. daily, or call us at 031 207 6108. Halton's, where every bite is a delight.
Getting real through your day. Radio Al Ansar.
Let's chat on Radio Ansar. We're discussing men's health and the new technology that deals with PSA. Any questions, you may forward them to us via WhatsApp on 060-904-1056. And our special guest this evening is Dr. Lucio Fritella, a specialist urologist. Now, Dr. Fritella, for men that are diagnosed with prostate cancer, what new treatment options are available that didn't exist a few years ago?
The treatment of prostate cancer obviously depends a lot on whether the disease is still organ confined, or what we call it organ confined if it's only in the prostate, or whether we determine via our CT scan or our PSA level, whether we determine that we feel there's a high risk that it's spread outside of the gland. So when the prostate cancer is still organ confined, we have a lot of treatment options that are able to cure the disease. So we still aim for treatment with curative intent in patients who have got disease that's still within the prostate. So the most sort of talked about and fashionable new treatment for prostate cancer in that organ confined setting is a so-called robotic or robot-assisted radical prostatectomy. So that is surgical removal of the entire prostate, along with some of the tissue around the prostate, and often combined with a dissection of some of the lymph nodes in the pelvis. And the modern twist on that is that we now use a robot. So the robot is a very cool device and a very cool system. It's a structure that has multiple arms that sit over the patient. Obviously, the surgeon inserts all the ports, and then the robot works through those ports, controlled still by the surgeon at a console, almost like a gaming console. So the surgeon will sit in or near the same theater with a view of the camera that's inside the patient, and two sort of handles or joysticks and some foot pedals, and you can control all the arms of the robot, which can twist and turn and tie sutures and cut and burn and coagulate, all from the comfort of a chair next to the patient. So this procedure is becoming quite fashionable. In terms of treating the cancer, it's not any better than the previous methods that we have been using. But it does seem to be a bit better because of the better vision and the better access to difficult areas to operate on. Because if you imagine the pelvis or the prostate is sitting inside a very narrow human pelvis, and to get your hands in there and underneath behind the pubic bone to tie sutures and gets a bit fiddly. So the robot takes all of that dexterity out of the equation, because the robot firstly is situated in a better position to access that area, and secondly has got a lot of movement within the joints that enable it to do these meticulous movements with quite a lot of ease. So the benefits of doing the robotic surgery is that the surgery is slightly quicker than it used to be. There's much less blood loss than there used to be. And the area where we reattach, because remember, you've still got your bladder and you've still got your urine pipe, and you've now removed that whole structure that was connecting the two. So that area where we reconnect the bladder to the urine pipe, that bond is much easier to do. So there's less issues with the anastomosis, which we call the anastomosis, which is the joint between the bladder and the urethra. So that is a bit easier, and there's a bit less leak in that area when we're doing a robotic. Any surgery on the prostate does have, also again, comes with significant risk factors. There's risks of the surgery itself, of an anesthetic, and of the blood loss and all of that stuff. And then there's some side effects of the surgery that many men find a bit disruptive. The most important two that are the most disruptive to life is that the urine leak, which is very common after this type of surgery, as well as the erectile dysfunction, or the sort of performance problems in the bedroom after this type of surgery. It's very common. It's the robot is able to do a so-called nerve sparing technique, where because of the better vision, you can actually visualize that nerve that runs out just alongside the prostate, which is important for erectile function. So it can preserve some erectile function, but we always warn our patients before any surgery on the prostate that there is a significant risk of both urine leakage after the procedure as well as erection problems after the procedure. Luckily, a lot of our patients do tend to be older gentlemen, so this can be less of a concern. But again, having said that, we still find many men that will be their primary complaint after such a procedure. So that's sort of the most modern treatment. We can talk about some of the more common, or the common sort of hard and fast or old-fashioned ways of treating prostate cancer that are still commonly performed. Not many people are doing open prostate surgery, which is that same surgery that we now use the robot for, because of the risks of the surgery, and there are better options which result in similar cure rates. So there's a procedure I'm sure you're familiar with. It's called brachytherapy, or prostate brachytherapy, which is a procedure where we implant small radioactive seeds into the prostate, and we use a very also very technologically savvy procedure where we specially map the prostate to tell us exactly where to place the seeds to achieve the maximum radiation exposure to the prostate and limit the radiation exposure to the surrounding organs. So it's a very nice procedure, because you have very good cancer treatment with much fewer risks in terms of your surgical risk, and some fewer complications. Obviously, no surgical procedure has no complications, but the brachytherapy seems to be quite well tolerated by most of our patients. The main side effects and issues we have after brachytherapy, again, is your urinary symptoms. So patients have sort of irritative symptoms because their bladder is exposed to that radiation. Even though we try and limit it, there's always some risk to exposing the bladder to the radiation, and that radiation change in the bladder makes it very irritable. So patients often have frequency of urination and urgency, and feel like they constantly need to empty their bladder, even if there's minimal amount of urine. There is also some collateral radiation damage to the rectum, which can cause severe symptoms in the back passage as well. with some blood from the back passage, difficulty passing stool, pain passing stool. So it's not completely benign and completely safe procedure. But the benefit of the brachy is that the procedure is very short. It only takes half an hour to 45 minutes of anesthetic. And there's no cutting, there's no bleeding. So all of those risks are taken off the table compared to doing something radical like operating. And you end up with a very similar side effect, and you end up with very similar oncological outcomes. So in our practice, we almost exclusively offer our patients brachytherapy. We do offer them everything, but we do sort of favor brachytherapy for our patients. And most of them are fairly satisfied with the outcomes. There are certain situations where you would recommend removing that prostate as opposed to doing brachytherapy. So your patients who are younger, that you don't want to take the risk of leaving behind any cancer for that longer follow-up period. If your guy's already in his 60s, you're not going to have to follow him up for that much longer. If a guy's in his late 40s, you've got to follow him up for potentially 30 or 40 years. So in that scenario, it may be better to remove the gland entirely. And also in patients who have a lot of a very large prostate that's causing a lot of symptoms and blockage of urine, in those patients, the brachytherapy is not as easy to do because you have to insert many more pellets, and the side effects and the risk factors in that gland are much worse. So there are some scenarios where we would still recommend removing the gland, and then we would obviously send our patients to our colleagues who are doing the robotic surgery.
Doctor, there's two questions.
So just briefly, just while I'm on this treatment thing, we can do your questions. It's fine. We can just go back to this. It's fine.
Let's go to the treatment thing. They will deal with this one time. I think let me complete first.
So those are sort of your options for your organ-confined disease. When we suspect or when we confirm that the prostate cancer has escaped the prostate and is now called metastatic, whether it be to the lymph nodes or to the bones, then we normally put our patients on we call it hormone deprivation therapy. Prostate cancer is very sensitive to testosterone. So it uses testosterone as its main growth factor. In fact, the prostate itself uses testosterone as its main growth factor. And when there's cancer there, if we remove that source of the growth, so removing the testosterone will limit the progression of the disease in patients who've already got cancer that's spread outside the prostate. Whether we can't treat it, we can't cure a disease that's already in the bones and already in the liver and the lungs and whatever. We can't remove all of those structures. So we're now trying to reduce the impact of that disease. So that's when we use hormone therapy, where we block the body's production of testosterone using medications or using surgery to try and limit the growth and spread of that cancer. That tends to work generally for about 2 to 4 years, depending on the disease. And eventually the prostate cancer no longer requires testosterone to grow and will still continue to grow in spite of patients not having any testosterone in their body. In which case the options become become limited. But there are some new options in that field as well. There's a substance called lutetium-133, which is a nuclear ligand, and what that is, it's a special protein that's bound. It's a special therapeutic agent that is bound to a protein that connects to the prostate tissue wherever it is, and kills those prostatic cancerous cells. So in patients who have got advanced disease where there's multiple areas of disease in the bones and outside of the prostate, that lutetium-133 is a new agent, a novel agent that can delay the progression of the disease further.
Thanks. The first question comes says, "Hi doc, does taking Nebido, NABIDO, causes prostate cancer?"
So it's again a controversial a controversial question. Nebido is a testosterone replacement agent, so it's obviously giving the body more testosterone. Nebido specifically is an agent that mimics the body's normal cycling of testosterone much better than the other agents that we have used historically to replace testosterone. So the risk, or the question is giving extra testosterone to a patient increasing their risk? Because we know testosterone is required for prostate cancer. So if we're going to give our patients testosterone, is that going to affect their prostate cancer or increase their risk of getting prostate cancer? So we always monitor our patients. If we do start any male patient on testosterone therapy, we always measure their PSA. And we always do a rectal examination on them. And if we find anything suspicious at that stage before initiating testosterone therapy, that would preclude us from starting that therapy. However, what the data seems to suggest is that low testosterone is actually a risk factor for prostate cancer, which seems a bit upside down based on what we've said. But in patients who don't currently have prostate cancer, there's no risk to giving them testosterone in terms of causing prostate cancer. There is a risk if a patient has a prostate cancer. If you give them testosterone, you're going to increase the growth of that prostate cancer. But if we have no confirmed prostate cancer, testosterone replacement therapy is completely safe.
Thank you for that.
I don't know if that answers the question.
I'm sure it does. Thank you for that, Doc. Okay, the next question comes through. It says that you mentioned that erectile dysfunction or erection problems are one of the side effects of the procedures. Can these side effects be addressed, and are they reversible?
Again, it depends on what the cause of the damage is. So if we've cut the nerves completely on both sides, it will be difficult to have normal erections after that. What we do now is we start patients even before we operate on them. We start them on medication that supports the erection and supports the pelvic blood vessels and supports the pelvic nerves, so that we try and optimize as much as possible what scenario we're going to have after the surgery. Because patients often account things that are there after an operation, and they blame the operation on something that may have already been there a little bit before the operation. Now they've got a nice excuse. But we do know that prostate surgery does cause erectile dysfunction because of physically we're cutting the nerves that cause erections. So the best way to mitigate for that is to start treating before the surgery. We already start them on medication that will improve their erection quality. And then during the recovery, we already started early on as well. We continue that medication to increase their erections. The other options, obviously, if we don't see any recovery or if we don't expect any recovery, there are some surgical devices now that are available, in which we actually physically implant a sort of erectile body into the penis. There's a few versions of this device. Some of them we call them malleable and then inflatable. So your malleable ones, it's kind of like a soft but hard piece of plastic that we implant into the penis. And so the penis is kind of always partially erect. And that can be then improve sexual function. The other options are inflatable devices, where it's a much more complicated system, where you have chambers that we insert into the penis, and those chambers are filled with fluid. And that fluid is stored in a reservoir that is sort of hidden discreetly behind the scrotum, and at the push of a button, that fluid rushes out of that reservoir and fills the implant. So it's sort of a more natural type of erection in patients who have completely no erectile function after this type of surgery. So there are still options after this surgery if sexual function is very important. But again, you need to go into that operation knowing that there may not be sexual function, there may not be recovery of erections after the procedure. It is one of those things we do our best to mitigate, and we treat what we can treat, and whatever your resources are, what your funds available are, there are options, but these things do become increasingly more expensive as well, and require further surgery and more invasive stuff to try and get to sort of a normal sexual function.
It's almost time for us to take an ad break. And on the other side of this, Doc, there's two other questions come through. I'm just going to mention the first one so you can just consider it during the break.
Okay.
Doc, what are your thoughts on prostate embolization as a treatment for enlarged prostate? But we can answer this after the break.
Okay.
Audio across the world on radioalansar.co.za.
You've spent all that time, effort, and energy putting together an incredible business. Now, you need to tell people about your business. Advertising and marketing, it's what we do. Listen to this.
Absolutely amazing. It's been my first experience working with a radio station. So you don't actually know what to expect. And you also feel like, you're just going to be a number. But at Radio Alansar, was just not a number. I think the support that we've got has been amazing. You guys have been absolutely amazing. You guys have opened doors for us that a couple months ago I wouldn't have thought possible. I think the support for me has been the greatest. It's so widespread because you guys are on YouTube Live, Facebook Live, not just radio based. We've got people in Johannesburg listening to you guys. So it's so widespread. We're getting that marketing.
Get in touch with our sales department on 031 208 1601. Speak directly to your target audience.
There's nothing quite like the taste of a traditional family meal, and at the heart of every great dish is a key ingredient that brings it all together. That ingredient is Sunfoil pure sunflower cooking oil, made from only the finest sunflower seeds. It's a perfect way to enhance the taste of your family's favorite foods. Sunfoil cooking oil is more than just oil. It's the key to bring your family together over a delicious meal and making every bite taste better. Remember, the key ingredient to a great family meal is sunfoil. Tradition just tastes better.
Looking for the most affordable family restaurant in Durban? Head on down to Fire and Ice in Overport. Enjoy breakfast deals from R39.90, killer steaks from R99.90, delicious pastas from R59.90, milkshakes from under R20, and all burger deals under $100. We've got something for everyone. Relax while the kids have fun in the play area. Safe parking on site and free delivery. Visit us at 460 Peter Makaba Ridge Road, next to the Atrium, Overport City. Fire and Ice, where family dining meets fantastic flavor.
Who's ready for an inspiring conversation with me, Shabnam Ismail? Join me this Sunday, November 24th, 4 p.m. on 90.4 and 105.6 FM as we discuss sports injury and recovery with experts. Stay tuned and set your reminders.
Radio Alansar, Durban, 90.4 FM. Peter Maritzburg, 105.6 FM.
Let's chat on Radio Alansar with myself, Faizal and Suleman. Our topic for discussion this evening is men's health and the new technology that deals with PSA. Our special guest, Dr. Lucio Fritella, and Dr. Fritella is a specialist urologist. Doctor, just prior to the ad break, we had two questions came in. The first question was, what's your thoughts on prostate embolization as a treatment for enlarged prostate?
So, prostate embolization is a technique that's performed by our colleagues in the interventional radiology field. So these are specialists in X-ray and that sort of thing. And what it involves is blocking the blood supply to the prostate. So this is now sort of a different topic to the prostate cancer topic, because this is more as a treatment for benign prostatic hypertrophy. So benign prostatic hypertrophy is a patient who presents with an enlarged prostate in which there is no cancer. The PSA might be high, might be low, might be normal, might be nothing, whatever. The PSA is not really an issue in BPH. So it would be a patient who we've confirmed has got no cancer there. It is useful as a strategy, especially in patients who are not fit for other more invasive surgical procedures, because obviously it doesn't involve a long operating time. It doesn't involve a serious anesthetic. It's probably just some sedation that they can give. And then, so in your patients who are a bit more frail, a bit older, but who have a lot of bleeding from their prostates and a lot of obstructive symptoms from their prostates, it is definitely an option worth considering. If your patient is fit for surgery, the surgical options are much more durable, much more well-researched. In terms of BPH, it's a different conversation. We can talk about it if you'd like. But the newer modalities there, the newest modality there is a procedure called a HOLEP, or a laser enucleation of a prostate. So it's sort of replacing what we used to do was cauterize the prostate and cut the prostate from inside the urethra, starting from the inside and working our way to the outside of the prostate. Whereas now what we can do with the laser fiber is we still going through the urethra, so it still doesn't involve any cutting of the bladder or cutting of the abdomen. We go through the urethra with a laser fiber, and we go around the prostate, starting from the outside. Instead of starting from the inside, moving our way out, we start from the outside, and we go around that whole prostate, and we push that prostate into the bladder, and then we morcellate it or chop it up in the bladder, and we suck out all those pieces. So that's sort of the newest. That's more in terms of your benign disease. That's becoming the gold standard, and it's very fashionable at the moment way of treating BPH, not prostate cancer, obviously.
I think related to that is, says Doc, using Cialis 5 mg daily help with reduction of an enlarged prostate?
Not really. It won't physically change the size of the gland. Your size of your gland is determined mainly by your testosterone level and by your genetics. And some men will have a huge prostate, and some men will have a normal-ish sized prostate. But Cialis or its cousins, Levitra and Viagra and those kind of drugs, what we do know is that they do help with the symptoms. We're not quite sure of the mechanism, but it has to do with improving blood flow and the general inflammatory environment in the pelvis, around the bladder, around the prostate. So we often use it combined with your more standard options, which are we call them alpha blockers. So those are drugs that relax the bladder neck and relax the prostate. You combine those drugs with your Cialis, and there is some improvement in the symptoms compared to just using one agent on its own. It doesn't change the size of the gland. Even your alpha blockers don't change the size of the gland. The only agent that does change the size of the gland is a drug called finasteride, which acts on the pathway where your testosterone in your blood is converted, in the prostate, is converted to a more potent type of testosterone. And that we know that potent testosterone, called DHT, causes significant growth in the prostatic tissue. So if we can block that conversion, then we can reduce the actual physical size of the prostate. So the only drugs that change the size of the prostate are your finasteride and dutasteride, or your 5-alpha reductase inhibitors. Unfortunately, those also can have some sexual side effects and lifestyle side effects, in that because they are reducing your available testosterone level, they do have can have some of those effects where there's less sort of libido and that kind of thing, yeah.
Doctor, how often should a man with an elevated PSA levels undergo monitoring, and what kind of follow-up tests might be recommended?
So it depends. So if a man has an elevated PSA, we're already assuming that, well, we need to find out what's causing that elevated PSA. So that's different to a man who's got a normal PSA in terms of at what interval should we repeat measuring it. So if a guy's already got a high PSA, we have to do something. So whether that's do your fancy imaging, do an MRI, or do a prostate biopsy, a guy with a high PSA, we can repeat it maybe once to check that it's definitely high. Because sometimes what happens is a guy will come in with symptoms and feel a bit uncomfortable and having difficulty passing urine. You measure his PSA, it's quite high. And in that situation, it can be that there's some acute pathology, like an acute prostatitis or an acute inflammation of the prostate. So in some scenarios, we would recommend repeating a PSA in about 6 weeks after doing one that is proven to be elevated before we jump down to doing invasive testing. So your patient who comes to you de novo, like out of the blue with a high PSA, it is worth repeating that test just to confirm that it is actually elevated. It's pointless doing it straight away. You can't do it one day and then the next day. You need to give it time to settle. So you give it about 6 weeks. If that 6 weeks period goes by and that elevated PSA persists, then you need to act. If that 6 weeks period goes by and the PSA has gone down, then you can be a bit assured and say, okay, maybe it was just some sort of infection.
Now, how is personalized medicine changing the way we approach prostate cancer and PSA levels? Can a man's unique genetic profile help guide treatment?
Yeah, I don't know too much about this field. I do know that there are some genetic disorders or some genes specifically that confer increased risk for prostate cancer. So the same genes that are responsible for that are found in breast cancer patients. So your BRCA1, BRCA2 genes are very important. So if you're known to be a carrier of those genes, it's very important that you start testing earlier, because we may that will sort of be in that higher risk category that we need to start testing you from the age of 40 to see whether you're going to develop prostate cancer or not. So there's a few genetic markers that we look for, but again, you would need to know either based on your own family history, like maybe a mom had a breast cancer and they tested her and she's got a BRCA. You're not just going to test everyone for BRCA1, BRCA2 in the general population, because it's going to be very expensive, very time consuming, and you're going to have a lot of misses. So in terms of individualizing your screening, you need to know your own risk factors. You need to try and, a lot of our patients don't know their family history that well. So it's important to try and figure out what diseases your father had, what diseases your mother had, your uncles, your brothers. It's not always easy. Not everyone is open about, especially when it comes to sort of the urological conditions. Everyone's a bit shy about talking about prostates and testicles and those kind of things with their family members. So it's often an issue, sort of socially, that men aren't aware of their own risk factors because they never knew that their dad had prostate cancer because no one ever spoke about it in the house. So that's my one recommendation in terms of personal medicine, is that you need to be aware of your own risk factors, be aware of your own sort of, you can't be aware of your own genetics, but sort of be aware of your own family history. And, if you know that you are high risk or feel that you may be high risk, then maybe go and see someone sooner than normal.
Doctor, what do you foresee for the future of prostate cancer diagnosis and treatment over the next decade? Are there any breakthrough technologies on the horizon?
So I think what we spoke about, it's all the stuff I don't really know much about because it's in the future. But the way medicine is going in general is more towards that sort of highly individualized approach, where we look at your specific genetic makeup, we look at your specific disease profile, and we can probably in the future even manipulate your own genetic code, either with insertions or deletions of specific genes. So genetic therapy is going to be a role in the future. We're not there yet, but it will probably be a thing in the future. The other important thing is these theranostic agents, where we combine sort of radiation type proteins to molecular markers and molecular biomarkers to assist in more targeted treatment. Because our problem with prostate cancer, with any cancer, is that you end up causing a lot of collateral damage to other organs, to other structures in the body when you're trying to treat the small focus of some sort of cancer that may or may not be there. And you smash the whole prostate, and you smash the bladder, and you smash the rectum with radiation and surgery and whatever. And okay, you've taken out the 2 centimeter prostate cancer. So what we need to work on as surgeons and as clinicians is how do we find that 2 centimeter cancer, and how do we remove it without causing collateral damage? So that's where we sort of need to be focusing our attention.
Now, aside from PSA testing, what lifestyle factors like diet, exercise, stress management, what lifestyle factors can impact on prostate health?
So there's a lot of sort of obviously you want to live a healthy lifestyle, because that's for 2 reasons. The one is a healthy lifestyle will limit your exposure to many risk factors that can potentially cause cancer. So that means a healthy diet, lots of vegetables, lots of fruit, cooked tomatoes, cooked vegetables. That sort of stuff is very good. And obviously maintaining a healthy weight, trying to exercise. It's difficult in our life, but it's important to get some exercise. We all struggle. The benefit of that is firstly to reduce your risk, but also if something does go wrong, if you are now faced with this diagnosis, you're in much better shape to deal with it. If you're fit and healthy, whatever diagnosis you get, you will be in better shape to deal with whatever treatment is required. If you're already overweight and you smoke and you've had a heart attack and a bypass and a thing, when you get your prostate cancer, it makes our life as a surgeon more difficult, and it makes your life as a patient much more stressful. So in terms of, there's nothing specific to reduce your risk of prostate, although there was a study that said frequent ejaculations is one of the main proven benefits or proven mitigating factors in prostate cancer. Is they say 21 to 24 per month. So regular sex, exercise, healthy diet, healthy lifestyle, all of those things will contribute to your prostate health, but also your general health. And what we want is healthy patients, even if they have a specific disease. If the rest of our patient is healthy, it makes our life much easier and their life much easier as well, in terms of dealing with chemotherapy, surgery, all of the hits that you're going to have once you get a diagnosis.
I think you've answered the next question that's come through. The next question says, is lack of sexual intercourse a risk factor for prostate cancer?
So yes, kind of.
Yeah, in fact, you did answer that, yeah. Now, how do you approach conversations with men who are worried about prostate cancer, especially if they have elevated PSA levels but no other symptoms?
Yeah, so as I alluded to, and as when we remember the anatomy of the gland, unfortunately, prostate cancer doesn't have symptoms, and that's why we've developed through the Prostate Cancer Foundation and many organizations internationally as well. We've tried to develop these screening programs and screening guidelines, because prostate cancer typically doesn't produce urinary symptoms until it's very advanced. So our conversations that we tend to have are patients who've gone to their GP and the GPs have done a PSA on them and it's come back as elevated, and now we have to have that conversation with them. So for us, what we do tell our patients is that there's 2 important things about prostate cancer. The one is that you always have time. So we don't rush our patients. We don't force them into making any decisions. Because the other important thing is that prostate cancer, if you had to choose, if you got told at the beginning of your life what cancer you want at the end of your life, and you got this list in front of you, you would probably choose prostate cancer.
Okay.
There are obviously some unlucky patients who have that aggressive disease where it affects them at a much younger age and it's much more aggressive and tends to present that's already spread out the body or out the prostate, at least. So there are those unfortunate patients, but a lot of our patients who are coming from GPs with their PSA sort of in this mid-range gray zone kind of thing, we always reassure them. We tell them, you have time and you don't need to be afraid. Whatever we do, what we know about prostate cancer is that even if you leave it untreated, a lot of the time your life expectancy will not be affected. So it's an alarming diagnosis to hear or to think about, because you hear this big cancer word and we all have these images in our head of what cancer means. But with prostate cancer, it's one of the reasons why urology is quite a nice field, is because prostate cancer is one of those cancers that A, is not very aggressive, and B, is very treatable. Even advanced cancers, you can still sort of offer your patients reasonable quality of life and some extension to their life after their diagnosis. So we tend to be quite positive with our patients when we diagnose them or when we have this conversation. So we don't try. It's important to maintain a positive attitude, especially with prostate cancer, because it can be quite an indolent disease.
Next question, I think we've answered in the beginning of the program, but I'm just going to ask the question for the benefit of the listener. Please ask Doctor, what is an elevated PSA?
So we never spoke really about the numbers. So generally in South Africa, it does tend to differ internationally and depends on your age as well. So what we use in our practice is a cutoff of 4 millimoles per deciliter. Okay, so that's, you'll go to the lab for a blood test and they'll give us a number and it'll either be 4 or less than 4 or more than 4. So if it's more than 4, we consider that an elevated PSA. There's some situations, so your younger patient in his 40s, 2.5 is probably considered elevated already. So it does depend on some situations. There are also some things that we know to cause an elevated PSA. So things like sexual intercourse, actually, or if you've been for any surgical procedures on your prostate, or you had a scope, or you had a catheter, or something went wrong, or you went and had a bad bladder infection, all of those things can cause that PSA to be elevated. But in terms of the number itself, we look at 4 as our sort of gold standard, our golden number. So if your PSA is more than 4, then we usually get referred to see one of us or one of my colleagues and get investigated further.
So below 4, you're okay. Over 4, you cause for concern.
Basically, yeah. That's the short answer.
What resources or tools would you recommend, Doctor, for men looking to learn more about their prostate health and PSA testing?
So the best resource in South Africa is probably the Prostate Cancer Foundation, which is a group of local urologists who've sort of come together and they work extensively in the community and they're trying to develop a set of guidelines. We still tend to, unfortunately, as a medical community, we always sort of beholden to international bodies and we follow a lot of international guidelines. So the Prostate Cancer Foundation is doing a lot of good work. They have a lot of resources on their website, and they're doing a lot of good work to support us clinicians as well, even just to give us guidelines in terms of when we should be doing PSAs, who shouldn't get a PSA, what's considered a normal PSA. So they recently, I think in May or June of this year, they released the so-called South African Prostate Cancer Guidelines, which are very useful as a reference, very useful for GPs to know about, and even for patients in general, because it's better to be informed, and you don't want to go down rabbit holes and finding incorrect information. So in terms of correct information, I would stick to the Prostate Cancer Foundation for prostate health, and then your local GPs should be well informed, urologists around town, wherever you live. Have a chat. We're not such mean guys. Most of us are quite a friendly bunch. So.
I'm sure you are, Doc. Now, Dr. Lucio Fritella, I want to thank you for joining me in the program this evening. It's been wonderful talking to you, and thank you. You know, the program's been quite informative as well, and I'm sure that those who have been listening will take cognizance of your advice. But if there's one key message that you'd like to give to men or to our listeners regarding PSA testing and prostate health, what would that message be, Doctor?
Well, I think for me, the key message is that don't be afraid of prostate cancer. Get screened, get tested. If it's early enough, we can sort you out. Even if it's late, we can sort you out. There's a lot of options in prostate cancer. It's not a death sentence. It's something that you need to know. Know your number, know your PSA. When your doctor asks you, you should have it on the tip of your tongue. Having said that, if I can just have one little moment to shout out, there's both the major labs in, I don't know if Durban's the same, but here in Pietermaritzburg, The two main laboratories, Lancet Laboratory and Empath Laboratory, are both sort of running concurrent promotions in terms of screening. So there's a day tomorrow at Eden Gardens Hospital in Pietermaritzburg where the Lancet Laboratory is offering free prostate cancer screening, and I think Empath for the month of November is also offering discounted PSA testing to all men who qualify. So there are some things on the go. So always November is always like sort of a men's health month kind of thing. So I think they're trying to tie it in with that. So yeah, go out there, get screened, get your test, know your number, and then come and see us if there's any concern.
Doctor, thank you so much for that, and thank you for joining the program this evening. You have a wonderful weekend, and before we round up, I want to thank Mondley for engineering for me. Mondley, thank you very much. Also, thank Hajar Koda for having the show, and Shabnam Ismail for having assisted as well. I'm back with you tomorrow morning, inshallah ta'ala, but you'll be listening to Ikra Warfam next, and let's listen to it attentively and derive the benefits. From myself, Faizal MJ Suleman, till tomorrow morning at 8 o'clock on Rise and Shine, it's Assalamu alaikum wa rahmatullahi wa barakatuh.
Good man, thanks.